This is the first installment in a two-part series which analyzes biological sex differences in immune responses to SARS-CoV-2 infection. This article focuses primarily on COVID-19 related viral entry as well as innate and adaptive immune responses COVID-19 and their correlation to epidemiological evidence. Part 2 will highlight the role of sex hormones in SARS-CoV-2 immune responses, examine sex differences in response to several vaccines, and consider their possible therapeutic implications. Men and women experience COVID-19 differently. Epidemiological studies show that, while males and females have similar infection rates, males are more likely to experience severe COVID-19 and die from SARS-CoV-2 infection. Women tend to have better prognoses. Pregnant females are the exception, as they have an increased risk of severe illness, hospitalization, intensive care unit, ICU, admission, mortality and preterm delivery. After excluding societal and behavioral factors, a question remains: what are the biological mechanisms driving these observed differences? Ho et al. Attempt to answer this question in their review, The Immune Response to COVID-19, Does Sex Matter? They consider several biological mechanisms in their work. This article will specifically examine differences in 3 stages of SARS-CoV-2 immune response: viral entry, activation of host innate immunity, and activation of adaptive immunity. Sex differences in SARS-CoV-2 immune response and in interaction to SARS-CoV-2 entails viral entry, then recognition of the virus and activation of host innate immunity, followed by activation of adaptive immunity. Ho et al. Found several potential mechanisms in these 3 stages which may explain the stronger immune responses seen in females. In viral entry, SARS-CoV-2 attaches and enters the host cell by binding to the angiotensin-converting enzyme 2, ACE2, receptors in upper respiratory tract cells. ACE2 receptors usually decrease inflammation, but the binding alters its function. As a result, ACE2 receptors critically influence SARS-CoV-2 entry to cells and can worsen SARS-CoV-2 caused tissue damage through inflammation. Ho et al. Explains some known sex differences in ACE2 levels which could contribute to the worst clinical outcomes seen in men. Some studies show that men express higher levels of ACE2, a factor which might increase vulnerability to infection. Males and females have similar soluble ACE2, SOS2, levels up until 12 years old. After, male SOS2 levels exceed levels found in females. One paper demonstrated that females required a lower dose of ACE inhibitors to achieve optimal therapeutic effect.